Welcome back to the deep dive. Today I want to start by asking you to think about reliability. If you bought a car, how many miles would you expect to get out of it before the starter motor failed? Maybe 100,000, 200,000.
If you're lucky.
Yeah, right. Now consider the internal clock ticking inside your chest. It beats roughly 100,000 times a day. Over a lifetime, that is billions of sparks, usually without a single misfire, and without you ever having to ask it to do its job.
It is the ultimate example of biological engineering. And what's wild is that it's not just a metronome keeping a beat. It's a responsive engine that adjusts to every thought, movement, and breath you take.
But like any mechanical part or biological part, in this case, the gears can get sticky, the battery can fade. Today, we are diving into the world of bred eurythmias, but specifically focusing on when the boss of the heart, the sinoatrial node or SA node, starts falling down on the job.
And this is a deceptively complex topic. A lot of people think, oh, slow heart rate, put in a pacemaker. But the chapter makes it so clear that that is a gross oversimplification.
Right.
We really need to understand the mechanism, literally the ions moving across the membrane, to understand why some slow heartbeats are deadly and others are just fine.
That's the mission today. We want to move past the what and get to the why. Why does the heart slow down? How do we prove the node is actually broken? And most importantly, when do we actually intervene? Because I was surprised to learn that seeing a terrifyingly slow number on a heart monitor doesn't automatically mean you need surgery.
Exactly. Context is king here. You treat the patient, not the ECG strip.
So let's start with the hardware itself.
The sinoatrial node, it's this tiny, tiny cluster of cells, but it's the electrical impulse behind every single heartbeat you have ever had. The heart doesn't wait for the brain to tell it to beat. The SA node just, handles that all on its own.
So geographically, where is this thing? It's sitting right at the junction of the right atrium and the superior vena cava.
Yeah.
But when you look at the histology, it's not just a clean lump of muscle tissue. It's described as heterogeneous.
Exactly. You've got the pacemaker cells, the myocytes, sure, but they're almost swimming in this mix of fibroblasts, endothelial cells, and a really dense matrix of connective tissue.
And that connective tissue, that's not just packing peanuts, is it? It's there for a reason.
Oh, it's a critical piece of engineering.
Yeah.
Think of the atrium as a giant electrical wet blanket.
Okay.
It's huge, and it's electrically stable. If that tiny little SA node touched it directly, the atrium's hyperpolarizing influence would just snuff out the spark before it even started.
So the matrix is insulation. It's like soundproofing in a recording studio.
It is. It lets the signal build up and actually fire out. And it ensures what's called unidirectional propagation.
Meaning one-way traffic.
Right. The signal goes out to the heart, but all that massive electrical noise from the atrium doesn't leak back in and mess with the timing.
It's a biological diode. That's fascinating. And speaking of plumbing, the blood supply is a bit weird too, right? It's usually from the right coronary artery.
In about 60% of people, yeah.
Oh.
But for the other 40%, it actually comes from the left circumflex. A lot of variability for something so vital.
But the real magic, I think, is the chemistry. The funny current.
The IFES,
Yeah.
the channel that never sleeps.
Right, because unlike other muscle cells that just sit there waiting for a signal, SA node cells have no true resting potential.
None. They are in a constant state of what's called phase 4 spontaneous depolarization. That funny current just slowly leaks sodium in, creeping the voltage up and up until it hits the threshold.
But once it hits that threshold, it's not the violent snap that you see in the rest of the heart's muscle, is it?
Correct. That's the key difference. Ventricular cells use these super fast sodium channels for an explosive, powerful contraction. The SA node, though, it switches to calcium channels for its upstroke.
So instead of a snap, it's more of a slow slide upwards.
A much gentler upstroke. It's safer for a pacemaker. Then potassium kicks in to reset the cell, and immediately that funny current starts leaking all over again.
And that cycle, if you say cut all the nerves to the heart, that happens at about 100 beats per minute. That's the intrinsic rate.
Which means biologically, our heart is actually wired to sprint.
But we spend most of our lives sitting at, 60 to 70 beats per minute? We have our foot on the brake.
That's the parasympathetic nervous system, the vagus nerve clamping down on the rate. And the node is physically clever about this too. The actual pacing site moves.
Oh, wait, it moves?
Yeah. At high rates, the signal starts in the top part, superiorly. When a brake is on and the heart slows, the pacing shifts down, inferiorly.
Okay, but here's the thing that always gets me aging. The engine has to wear out.
And it does. The intrinsic rate drops by about 5 or 6 beats per decade.
Yeah.
But if you look at a healthy 90-year-old, Their resting heart rate is often the same as a 20-year-old's.
So the engine is running slower, but the dashboard says we're going the same speed. How does that work?
Because the brake pads wear out. By the 9th decade of life, that parasympathetic tone, the brake, it fades away. So the sympathetic system, the gas pedal, takes over dominance.
So the raw engine is slower, but we learned to stop holding it back so much. That's an incredible physiological compensation.
It is. So let's start with the basics of the malfunction before we get to the detective work. When we say the sinus node is sick, what is physically happening in that tissue?
So normally, the sinus node is this tiny, really specialized cluster of cells up in the right atrium.
Okay.
It generates an electrical impulse completely automatically. That impulse spreads out and tells the whole heart to beat. In sinus node dysfunction, or SND, that cluster just gets unreliable.
Unreliable how? Like it's just tired?
In a sense, yeah. The tissue itself might be fibrotic, maybe scarred, so it fails to generate the impulse on time, or maybe it generates the impulse, but the signal gets blocked before it can even travel to the rest of the heart.
Let's start with the glitches themselves. The source material breaks it down into impulse formation first. This seems like the most straightforward one.
It is. The idea is simple. The spark plug is just not firing right.
This is where we see things like sinus bradycardia.
Exactly. The node is firing, the signal is there, but the metronome is just set way too slow.
And when we say slow, we mean less than 60 beats a minute. But it's about context, isn't it?
It is entirely about context. We're talking about inappropriate bradycardia.
Right. An Olympic athlete might have a resting heart rate of 45, and that's totally fine.
Perfect, even. But if you have a heart rate of 45 and you feel like you're going to pass out walking to the kitchen, that's a problem. The rate is too slow for what the body needs.
And the extreme version of this is sinus arrest, which sounds bad.
It's exactly what it sounds like. It's a pause. The node, just for a moment, fails to generate an impulse at all.
It goes on a coffee break.
Essentially, you look at the ECG and there's just a flat line where a beat should be. The silence is the clue.
But there's another idea in this formation category that I think is the most relatable. It's called chronotropic incompetence. Most people assume slow heart rate means you're sitting in a chair and your pulse is 40. But with chronotropic incompetence, your resting rate might be totally normal. Sitting there reading a book, heart ticking away at 70. You look fine. The doctor says, you're fine.
But then you try to do something.
Right. You stand up, you walk to the mailbox, or you try to run for a bus. Your body is screaming for more oxygen. Your muscles are saying, hey, pump faster, we need blood. And the heart just ignores the request.
It's like stepping on the gas pedal and the engine just hums at the same pitch.
Yeah.
No acceleration.
And think about what that feels like. You aren't in pain, not necessarily. You're just exhausted, dizzy. You have what we call air hunger. Your legs feel like lead. It's debilitating.
The notes mentioned a formula for this, something about age-predicted maximums.
Yeah, the classic formula is 220 minus your age. If you're 40, your max should be around 180. Technically, if you can't hit 85% of that during exercise, you have CI. And to find this, we use a treadmill test. The Bruce protocol.
The standard stress test. But the expert notes here point out a potential flaw. The Bruce protocol is really aggressive. The speed and incline go up very fast. It's a steep hill. But if the test is too short or too intense, you might miss what they call insidious incompetence.
Insidious. That implies it's hiding.
It is. If you force the person to max effort in 6 minutes, you see the peak. But you might miss the lag. You might miss the fact that during the light warm-up jog, their heart rate barely moved. The recommendation is to use slower protocols. You want to see the slope of the rise, not just the summit.
Got it. So we need to see how the heart handles the gentle climb, not just the final sprint.
Precisely. We need to see if the heart rate is matching the metabolic demand at every single stage.
Okay, so that's impulse formation. The spark is weak, or slow, or just plain missing. Now let's get into the more complex stuff. The disorders of impulse conduction.
This is the SA exit block.
So in this case, the SA node is actually firing. The spark is happening.
It is, but the signal is trapped. It can't get out into the atrium.
The door is locked.
The door is locked.
How do you tell the difference between no signal created and signal created but blocked?
I was wondering that. The SA node is tiny, right? It's not like you can see it.
It's microscopic. When you look at an ECG, those squiggly lines on the monitor, you are never actually seeing the SA node fire. It's just too small to generate enough voltage to reach the stickers on your skin.
Wait, really? So if we can't see the conductor, how do we know he's failing?
We look for the reaction. We look for the P wave. which is the atria contracting. It's like a shadow puppet show. You can't see the hands making the bunny, but you see the shadow. If the shadow disappears, you have to deduce what the hands did. Did they stop moving, or did someone just turn off the light?
Okay, putting on my detective hat. The sources went deep into these blocks.
The source mentions a type I block, but then it says we can't really diagnose it.
Not on a surface ECG, no. Think about it. If you can't see the starting gunfire, you can't measure the delay before the runner starts.
So it's invisible to us.
Without invasive testing, yes. So we really focus on type 2. And this brings us to Wenckebach.
Okay, I read this section 3 times. The math feels like it goes against all logic.
It trips everyone up, don't worry.
So with Wenckebach, the time it takes for the signal to get out of the node gets longer with each beat.
Correct. The node is getting tired.
Yeah.
Each beat takes a little more effort to push out the door.
But, and this is the crazy part, the result on the ECG, is that the heartbeats, the P-to-P intervals, they actually get shorter right before the pause. They speed up before they drop. How does the delay getting longer make the beats arrive faster?
It's all about the increment, the change in the delay.
The increment. Okay.
Let's try an analogy. Imagine you're passing buckets of water. The first bucket, you pass instantly, 0 delay.
Got it.
For the second bucket, you're a bit tired. It takes you 1 second to hand it over. So the gap between bucket 1 and 2 grew by 1 full second.
Okay, that makes sense.
Now for the third bucket, you're even more tired. It takes you 1.5 seconds. The delay is still getting longer, right?
Yeah, it went from 1 second to 1.5.
But look at the change. The first gap grew by 1 second. The second gap only grew by half a second. Because the amount of extra delay is shrinking, the buckets actually start arriving closer together.
Whoa. So the slowing down is decelerating.
Exactly. The conduction time lengthens, but by a decreasing amount. So on the ECG strip, you see the beats start to cluster together. Beat, 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 and then a pause.
And that clustering is the fingerprint of Wenckebach.
It is. It's the node warning you it's struggling. It's a relatively benign issue compared to the other type 2 block.
Mobitz 2.
The more sudden version.
Yeah, it's sudden. Type 2 isn't fatigue. It's a glorious, perfectly marching rhythm beat, 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 and then bam, nothing. A dropped beat.
No warning, no getting tired, just gone.
None. And what's cool if you're a nerd about this stuff is the timing. In type 2, the pause is usually an exact multiple of the regular rhythm. It's like the band kept playing in their heads, they just missed a beat, and then came right back in on time.
Okay, I see the distinction. One's a tired messenger, the other one falls into a hole. But here's the so what question. The guidelines seem to imply that figuring out if it's type I or type 2 might be a waste of time.
It's intellectually satisfying for us, sure, but clinically, it rarely changes the plan. We don't usually drag people into the cath lab for invasive testing just to put a label on the block. We treat based on how the patient feels, not the geometry of the squiggly line. That block becomes complete.
Then the door is welded shut, no signals get out at all. That's atrial standstill, and the heart has to rely on a backup pacemaker to keep going.
This brings us to the syndromes. We've covered slow and blocked, but Tachy-Brady Syndrome sounds like pure chaos.
It is the hardest to manage.
Imagine your heart's a car. 1 minute, you are flooring it, doing 120 miles an hour. That's the Tachy part, usually atrial fibrillation. The heart is racing, fluttering, totally chaotic.
And then
you take your foot off the gas, and instead of idling nicely, the engine just stalls. It crashes down to a dead stop.
So you're sprinting a marathon and then you just pass out.
Essentially. And it's one of the trickier puzzles in cardiology for that exact reason. You're fighting 2 opposite problems in the same heart.
So looking at the management guidelines for this deep dive, the obvious question is, which one do you treat first? Do you slow it down? Do you speed it up? Because anything you do for one seems like it would make the other just infinitely worse.
And that's the central conflict. Yeah. If you treat the tachy the fast rate, you risk the patient flatlining during those slow Brady episodes.
But the guidelines are clear on this, right? They say go after the fast rhythm first.
They do. Despite the risk, the consensus is to target the tachycardia.
That seems incredibly risky. I was looking at the rhythm strips in the source material we have, and I think I saw a pattern I want to ask about. These flat lines, the bradycardia, they don't seem random. They always seem to happen right after a big spike in the heart rate.
You've spotted the core mechanism. That's what we call an offset pause.
An offset pause.
It's not just that the heart is slow, it's why it's slow.
Yeah.
When the heart is racing, usually in atrial fibrillation, the whole system is just screaming electrically.
Okay.
When that noise suddenly stops, the heart's natural pacemaker, the sinus node, is basically stunned.
Stunned, you mean it's just overwhelmed?
We call it overdrive suppression. Think of it like walking out of a really loud concert into a silent room.
Okay. Your ears are ringing.
Exactly. Your ears are ringing. You can't hear normal sounds for a minute.
Yeah.
The sinus node is effectively deafened by all that noise.
Right.
It takes a few terrifying seconds for it to wake up and fire again.
So the logic then is if you can stop the screaming, the tachycardia, the natural pacemaker won't get suppressed in the first place.
That's the hope. That's the whole strategy. If you can control the atrial fibrillation, you remove the cause of the suppression, the offset pauses might just disappear.
And the patient might avoid needing a pacemaker altogether.
Potentially, yes.
Okay, but that brings us back to the tools. To stop that fast rhythm, you're usually reaching for beta blockers, calcium channel blockers.
The standard rate-controlling drugs.
But wait a minute. If you give a patient with a stunned heart a drug that's designed to slow their heart rate, aren't you just guaranteeing a longer, scarier pause?
And now you've hit on the medication paradox.
The medication paradox.
You are 100% right. Those drugs are essential, but in a Tachy-Brady patient, they can turn a 3-second pause into a 6-second one. It's a real catch-22.
So you're in checkmate, you need the drug, but the drug is dangerous.
Yeah.
How do you break that loop?
This is where the pacemaker's role completely changes. For most people, a pacemaker is just a fix for a slow heart.
Right.
Here, the pacemaker is a safety net. We implant it not because the patient always needs it, but so we can safely give them the drugs they need.
So the device is there to clean up the mess made by the medication.
Essentially, yes. It lets the doctor be aggressive with the tachy treatment. If the beta blockers work a little too well, the pacemaker just kicks in and catches the rhythm. It takes the bradycardia risk off the table.
That's a really fascinating way to think about it. It's an enabler for the drugs. I did see a bit in here on catheter ablation, though.
It's the high-reward gamble, you could say.
Yeah.
Instead of just managing the problem, ablation tries to fix it. To physically go in and burn or freeze the circuit, causing the tachycardia.
And if it works?
If it works, the fast rhythm is gone, the overdrive suppression is gone, and so the pauses are gone, no pacemaker needed.
But the guidelines are pretty strict on this part.
Very strict. If you do the ablation and the patient is still symptomatic when their heart is slow, or if the ablation just fails, then permanent pacing becomes a Class I recommendation. It's non-negotiable. You have to put that safety net in. So we have the what. Let's pivot to the why. The source makes this really clear split. Intrinsic versus extrinsic.
This is the absolute fork in the road for treatment. Intrinsic means the hardware is broken, the heart tissue itself is damaged.
And extrinsic means the software has a bug or the environment is wrong.
Precisely. Let's start with the hardware, the intrinsic causes. What's the #1 enemy of the SA node?
Joe, getting older.
Time.
We see a lot of fibrosis, that's scar tissue developing in the SA node. We also lose the actual pacemaker cells over time.
But you pointed out in the notes that fibrosis is actually normal.
To a degree, yes. If we looked at the heart of a healthy 80-year-old, we'd see some fibrosis. That's just aging. But sick sinus syndrome is pathologic. It's when that scarring crosses a line and starts affecting function. So just being old isn't the cause. It's an abnormal degeneration.
And it's not just age. Heart attacks play a role here too.
Right. Anatomy matters. The SA node usually gets its blood supply from the right coronary artery. So if a patient has an inferior heart attack, one involving that artery, it can cut off blood flow to the pacemaker.
And there was a term you mentioned, the Basal-Gerish reflex.
Yes, the Basal-Gerish reflex. It's an involuntary nervous system response that increases vagal tone. That's the brake pedal of the heart. In the setting of a heart attack, this reflex can kick in and make the bradycardia even worse. It's also why we have to be careful with drugs like morphine in these patients.
We also have to talk about procedural causes, like you go in to fix one thing and break another.
It happens. Specifically with ablation for atrial fibrillation, you're burning tissue to stop an arrhythmia. But if you burn too close to the SA node or its artery, well, you can silence the node. Next, we need to look for structural heart disease.
Right. If the sinus node is failing, is it because the cells themselves are dead, or is it because the neighborhood they live in is destroyed?
And the tool for that is the echo, the ultrasound.
Yep. A transthoracic echocardiogram. And we're looking for specific things. Infiltrative diseases are a big one. Something like amyloidosis.
That's when proteins start depositing in the tissue.
Exactly. It stiffens the heart tissue. If the sinus node is surrounded by these amyloid deposits, it can't function. Or we look for scarring from previous surgeries. If the right atrium is stretched or scarred, maybe from a valve repair years ago, The electrical signals just can't travel.
It's like trying to drive a car on a road that's been bombed out.
That's a great analogy. The car might be fine, but it's not going anywhere.
But let's talk about the software bugs, the extrinsic causes, because these are the ones we can potentially fix.
And this is where the first place we look is the medicine cabinet.
It's so ironic. We give drugs to help the heart, and they end up causing this problem.
It's a constant balancing act.
Beta blockers, calcium channel blockers.
Right, those are designed to slow the heart. So sometimes they just do their job a little too well. That's easy to spot. You lower the dose, the heart speeds back up. Diagnosis, drug side effect, not sick sinus syndrome.
But then you get into the weirder stuff. Psychiatric medications?
This is one that's often overlooked. Lithium, for example. It's a standard for bipolar disorder, but it can have a profound dampening effect on the sinus node.
Wow.
Tricyclic antidepressants, SSRIs, they can all impact rhythm. Even drugs for Alzheimer's, like Donepezil.
So a patient could be going to a cardiologist for fainting spells, and the real problem is their antidepressant.
It happens more often than you'd think. And look at the lifestyle section. Cannabis is on the list.
And eye drops. That one blew my mind. Beta blocker eye drops for glaucoma.
The body's a whole system. You put a drop in your eye, it drains into the tear duct, gets absorbed into the bloodstream, and the heart feels it. If you're sensitive, that can be enough to cause bradycardia.
So the first step isn't surgery, it's a medication review.
Always. Can we stop the drug? Can we lower the dose? If we stop the lithium and the heart speeds up, they don't have sick sinus syndrome. End of story.
Okay, so moving down the checklist, we've cleared the meds. Now we look at systemic conditions. You mentioned the thyroid.
Hypothyroidism, yeah. If your thyroid is underactive, it basically turns down the dial on your entire metabolism. Your heart rate drops right along with everything else.
And infections. Lyme disease is listed here.
Lyme carditis. The bacteria can actually infiltrate the heart's conduction system. And notice COVID-19 is on the list now too, along with myocarditis.
But there's one reversible cause here that I think needs a specific focus. Sleep apnea.
Ah, yes. This is a big one. And it's a source of a lot of misdiagnosis.
Explain this connection, because to me, apnea means you stop breathing. Why does stopping breathing make your heart stop beating?
It's a reflex, a kind of survival mechanism gone wrong. When you have an apneic event, your throat closes, you stop getting air. Your body panics. But physiologically, it triggers a massive surge in what we call vagal tone.
The vagus nerve. That's the brake pedal for the heart.
Exactly. It's the brake pedal. When you're choking in your sleep, your body slams on the brakes to conserve oxygen. We see patients who will flatline for seconds at a time, really long pauses, strictly because of their apnea.
So that sounds incredibly dangerous. If I'm flatlining in my sleep, surely I need a pacemaker.
You would absolutely think so. But the guidelines are very, very strict here. Asymptomatic pauses during sleep are typically not an indication for pacing.
Really? Even if the heart stops for several seconds?
If it only happens when they are asleep during an apnea episode, the treatment is not a pacemaker. The treatment is a CPAP machine. You treat the apnea. If you fix the breathing, the heart rhythm usually fixes itself.
That seems like a massive distinction for a doctor to make.
It's vital. The text really emphasizes determining the timing. Did the pause happen while they were awake or asleep? If you just look at a monitor report that says 3-second pause without asking, was the patient snoring at the time? You might operate on the wrong problem.
What about external triggers? Things that aren't the heart itself?
We look for high vagal tone. That's the body's internal brake clamping down too hard, maybe during an acute illness or even just severe nausea. You can get these scary-looking pauses.
But they're temporary.
Exactly. You don't want to implant permanent metal for a temporary flu.
What about carotid sinus, hypersensitivity, and neurally mediated bradycardia? The core issue is that the baroreceptors in the neck, which should be regulating your blood pressure, get triggered by almost nothing.
And they send a false signal.
A false distress signal straight to the brain. And the brain's response is to just slam the brakes on the heart.
And when you say slams the brakes, the literature is not exaggerating here. We aren't talking about a little flutter.
No, not at all.
We're talking about sinus bradycardia, a massive, significant slowing of the heart rate. I was reading that this specific type, it involves the cardioinhibitory component.
Yes, and that distinction is absolutely crucial. Most people have heard of vasovagal syncope, the common faint.
Sure.
But in this specific cardioinhibitory variant, the dominant feature is that the heart either slows dramatically or just stops for a few seconds.
And that's what's causing the syncope, the fainting.
That is what causes the recurrent syncope or that graying out pre-syncope feeling. It's all about the heart rate dropping off a cliff.
So if the mechanism is the heart failing to beat fast enough to keep blood flowing to the brain, the fix seems, well, pretty straightforward, right? You just bypass the faulty wiring. If the brain is sending a bad order, you install something to override that order, a pacemaker.
And that is the primary management strategy. For patients where that cardioinhibitory part is the main driver, pacemaker implantation is the go-to. The device sees the rate drop, and it just kicks in.
It's an engineering solution.
A direct engineering solution to a biological problem, in theory.
Okay, but looking at the outcomes data, it's not quite a mission-accomplished story. There's a real plot twist here with something called the vasodepressor effect.
Ah, yes. This is the physiological catch.
So the pacemaker keeps the heart beating, but the sources are clear that it can't stop the blood vessels from dilating.
Exactly. That same vagal tone that stops the heart also opens up the entire vascular bed and blood pressure plummets. A pacemaker can fix the rhythm, but it has zero control over that systemic pressure drop.
So you could have a perfect heart rate on the monitor, but the patient's blood pressure is still bottoming out. They might still feel awful.
They might, but here's the nuance in the management goals, and I think you were getting at this.
It's about the consequence.
Precisely. It's harm reduction. If we can prevent that profound bradycardia, that 3, maybe 6-second pause, the patient might still get lightheaded.
But they don't lose consciousness.
They're far less likely to lose consciousness and, suffer a fall or traumatic injury. We're basically trading a full blackout for a moment of dizziness.
Okay, so now let's get into the controversy, because the clinical trials on this are surprisingly messy. We're looking at patients who are drug refractory, so medication didn't work.
Right.
And the question is, does permanent pacing actually help them?
The results are mixed. And that frustrates everyone, clinicians and patients alike. The initial randomized trials look like a slam dunk.
Really promising.
Yeah, they showed significantly fewer fainting recurrences and a much longer time between episodes for the group that got the pacemaker. But then the follow-up studies came out, and the water just got murky. One major study completely failed to confirm those benefits.
And reading between the lines there, it seems like the elephant in the room is the placebo effect.
It's a huge factor. I mean, it is remarkably difficult to blind a surgery. Patients generally know if they have a pacemaker inside them or not.
Of course.
So for a condition like syncope, just the psychological assurance of having that safety net can actually reduce the frequency of attacks.
So the earlier trials might have been measuring the patient's confidence as much as the device's actual mechanical effect.
It certainly suggests that.
For the patient, it doesn't just feel like a number on a screen. It feels like this profound fatigue. It feels like exercise intolerance. You run for the bus, but your heart rate stays flat, so you feel like you're breathing through a straw because your cardiac output isn't matching your effort.
Or worse.
Or, in the worst cases, syncope.
Fainting.
Right. If that pause is long enough, we're talking more than a few seconds, blood stops getting to the brain and the lights just go out. That is usually what brings people to the ER.
Okay, so if I walk into a clinic and say I fainted or I'm just exhausted all the time, how do doctors actually prove it's the sinus node? Because the big takeaway I got from the guidelines is that proving this is surprisingly hard.
It is the central challenge of this whole condition. The mission, if you want to call it that, is correlation.
Correlation.
You cannot diagnose S&D based on a slow heart rate alone. You have to prove that the patient felt dizzy at the exact moment their heart paused.
Which brings us to the tools. So the first thing listed in any protocol is the standard 12-lead ECG, the sticky patches, the wires.
Yep.
But the notes here seem to suggest this is almost useless for diagnosis.
Useless is maybe a bit harsh, but insufficient is definitely accurate.
Why?
Just think about the logistics. An ECG records for, 10 seconds?
Right.
S&D is intermittent. It's totally unpredictable.
To the bank robber problem.
The what?
If you're trying to catch a bank robber, taking a photo of the lobby once a day for 10 seconds probably isn't going to catch him in the act.
Oh.
You're just going to get a picture of an empty lobby.
That is actually a really good analogy, yeah. You might see a slow heart rate on that ECG, sure. But lots of healthy people have slow heart rates. Unless the patient happens to feel dizzy during those exact 10 seconds, which is, statistically so unlikely, That strip tells you nothing about the cause of their symptoms.
So logically, we have to film the bank lobby 247.
Exactly. We need a movie, not a photo. And this is where we get into mobile telemetry. The protocol moves really quickly to Holter monitors for 24, maybe 48 hours, or event monitors that can last for weeks.
The source material also explicitly mentions consumer wearables here, smartwatches.
It does.
And I found this interesting because usually medical texts can be a bit dismissive of consumer tech. This one seemed to embrace it.
The tone has definitely shifted in the last few years. The text notes that these devices can now provide electrograms with excellent fidelity. That is a complete game changer for diagnosis.
Because the patient becomes the sensor.
Right. Instead of wearing some bulky monitor for weeks hoping to catch a spell, the patient feels dizzy, they tap their watch, and they capture a PDF of their rhythm right then and there.
And they can just email that to their cardiologist.
Exactly. We've gone from the doctor will see you now to the doctor will see your data now.
But wait, I want to push back on that a little. Doesn't that also just create a lot of noise? I mean, my watch tells me my heart rate is low when I'm sleeping or just watching TV. Am I sick?
And that is the danger. That's why that correlation rule is the gold standard we have to keep coming back to.
Yeah.
If your watch says your heart rate is 40, but you feel totally fine, that's not a disease. That's just data.
Now, I want to get to the most technical part of the source material, the invasive electrophysiology study. This sounds intense. We're actually going inside the heart.
We are, but I have to preface this. You can consider it, but it's rarely necessary. We can usually diagnose SND with all the non-invasive stuff we just talked about, the monitors, the treadmill. But if the diagnosis is still murky, if the patient keeps fainting and we absolutely cannot catch it on a monitor, we might do an EP study.
So you thread wires into the heart. What are you actually measuring?
We're trying to isolate the sinus node. We want to see how it performs without any outside interference. And to do that, we have to chemically block the nervous system.
Block it how?
Pharmacologically, we give intravenous propranolol and atropine.
Propranolol blocks the adrenaline.
And atropine blocks the vagus nerve. So we're basically cutting the phone lines to the brain. No adrenaline to speed it up, no vagus nerve to slow it down. We want to see the intrinsic heart rate, the heart's naked, natural speed.
That is wild. It's like disconnecting the engine from the car's computer to see what the true idle speed is.
That is exactly what it is. And there's even a formula for what that speed should be.
I have it here. 118.1 minus 0.57 times your age.
Science always tries to be precise.
That is painfully specific.
It is, but it gives us a baseline. If your heart's intrinsic rate is significantly lower than that calculated number, it helps prove the sinus node itself is the problem. It's not the drugs, it's not the sleep, it's not the nerves. The cells are failing.
And then there are other metrics, right? Sinus node recovery time.
Yes, SNRT. Basically, we pace the heart really fast with the wires for a bit, then we stop abruptly and use a stopwatch to see how long it takes the sinus node to wake up and start firing again on its own.
And if there's a long, awkward silence.
That's bad.
But, and this seems to be the theme of this entire deep dive, even if that number is low, even if the recovery time is long, the text says, that's still not enough for a pacemaker.
You catch on quick. The source states it explicitly. There is no evidence that abnormal SNRT or SACT alone can be used as an absolute indication for permanent pacing.
It always comes back to the symptoms.
Always. You treat the patient, not the number. If they have a slow intrinsic heart rate but they feel fantastic, you leave them alone. We don't pace numbers.
So let's bring this all together because this really is a flowchart of decisions, not just one single test.
It is.
I'm tired, I'm dizzy. We try to catch the crime on tape with a wearable or a monitor.
Correct. We have to establish that correlation.
Yeah.
No correlation, no diagnosis.
And then we enter the rule-out phase. We check the medicine cabinet. We check the thyroid. We check for sleep apnea.
Crucial step. We clear all the red herrings. We stop the meds. We treat the sleep.
Then we might put them on a treadmill to see if the heart can handle the work. We might take a picture with an echo to see if the structure is sound.
And only then, if the symptoms align with the data, and there are absolutely no reversible causes, only then do we label it sinus node dysfunction and start talking about a pacemaker.
So context is everything.
Yeah.
But that context must change with the patient, right? I mean, a heart transplant patient is a whole different ballgame.
A completely different world. A transplanted heart is denervated, its nerves are cut, so it has no break. It naturally wants to beat at 90 to 110.
So a normal rate of, say, 60 is actually bradycardia for them.
It's a significant problem. We call it chronotropic incompetence.
Wow. Any other cases with unique triggers like that?
Spinal cord injuries are another one. Routine things like suctioning a breathing tube or just turning the patient can trigger what's called autonomic dysreflexia.
And that causes the heart rate to just...
To bottom out. It's a chaotic storm of nerve signals.
Okay, so let's say we've ruled everything out. The meds, the flu, the unique contexts. The patient needs a pacemaker. Is there a magic number? Like if you hit 39, you get a device?
Nope, no magic number. The decision is driven entirely by symptoms.
So you have to connect the slow rhythm to dizziness or fainting.
You have to make that correlation. I mean, you take a well-conditioned athlete, their resting rate might be 35 and they feel amazing. We do nothing.
I did see a note about using a drug, oral theophylline. Is that a long-term fix?
Almost never. We mostly use it as a kind of test drive. If the drug speeds up the heart and the patient feels better, it confirms a pacemaker will probably help.
This brings us to the guidelines. Class I indications, the definite yes list. This is your symptomatic bradycardia, your Tachy-Brady Syndrome, and symptomatic chronotropic incompetence.
And class 3 is the don't do it.
Right.
Yeah.
Asymptomatic patients, or people where the cause is reversible. Pacing them is malpractice. Okay, so the decision is made. The symptoms match the data. We're going to pace. Now we get to the tech, because it's not just one size fits all.
No, the technology has come a long way.
Yeah.
But to understand it, the sources really geek out on something called the NBG code.
I saw that. DDDR, VDI. It looked like a secret code.
It does, but it's just a simple 4-letter system that tells you exactly what the pacemaker is programmed to do. It's the device's logic map.
Okay, let's break it down really quick. The first letter.
Chamber paced. A for atrium, the top chamber. V for ventricle, the bottom. D for dual, meaning both. It just says where the zap goes.
The second letter.
Chamber sensed. Where is the device listening? Same options, A, V, or D.
And the third is the response.
Right. Usually I for inhibited, which just means if the device hears a natural heartbeat, it stays quiet, it doesn't interrupt.
It's polite.
It is. But that fourth letter, the R, the text, implies this is a real game changer for quality of life.
R for rate response.
Exactly. This is for that chronotropic incompetence we talked about. Normally when you get up to run, your brain tells your heart to speed up. If your sinus node is broken, your heart rate stays at 60 and you can't function.
You'd pass out.
So our rate-responsive pacemaker has sensors in it, accelerometers that detect motion or others that detect your breathing rate. When it senses you're exerting yourself, it acts like the brain. It ramps up your heart rate to match your activity.
That's incredibly smart. It's mimicking the body's natural demand.
It is. And that gets to the big debate in the guidelines. Do you use a single chamber or a dual chamber device? If the problem is just the sinus node, the top chamber.
Why not just put one wire in the atrium? Keep it simple.
You would think so. Less hardware, fewer problems. But the data suggests that fibrosis, the scarring that causes this, is often a progressive disease. If your sinus node is scarred today, there's a pretty high chance your AV node, the next junction box down, will be scarred in a few years.
So if you only pace the top and the middle fails later,
you're going back for second surgery. So the standard of care, especially for older patients, is usually to put in a dual chamber, a DDDR pacemaker. It has a lead in the top and a backup lead in the bottom, just in case. It's an insurance policy.
Better safe than sorry. Okay, but let's talk about safety. This is still surgery. What can go wrong?
Well, you have the standard surgical risks: infection, bleeding, a collapsed lung from the needle puncture. You can even perforate the heart muscle itself.
But the text seemed to suggest the real long-term problem is the leads, the wires.
They are the least reliable component. Think about it. That wire is flexing with your heartbeat 100,000 times a day. It gets squeezed under your collarbone. Over a decade, insulation can fray, the wire can fracture. It's a very hostile environment.
And then there's the human factor. We have to talk about Twiddler syndrome.
Ah, yes. Twiddlers.
I thought this had to be a joke when I read it. What is this?
It's a rare but very real thing. A patient, sometimes subconsciously, will just fiddle with the generator in the little pocket under their skin. They'll rotate it, flip it over.
They're twisting the device in their chest.
Exactly. And when they twist the generator, the leads get wound up around it like spaghetti on a fork.
Oh.
And eventually, the tension pulls the leads right out of the heart muscle, and the pacing just fails.
That is bizarre and terrifying.
Yeah.
Which brings us to the latest innovation mentioned in the text, which seems to solve the lead problem and the twiddler problem. Leadless pacemakers.
This is the frontier. These are tiny, self-contained capsules about the size of a big vitamin pill. There are no wires, no chest pocket. The whole device is deployed via a catheter directly inside the right ventricle.
So no leads to break and nothing to twiddle.
Correct. But the early versions had a big drawback. If it's only in the bottom chamber, the ventricle, it can't coordinate with the top chamber, the atrium.
You lose that timing, the atrial kick.
You do. But the very newest generation of these has solved that. They have these incredibly sensitive accelerometers that can actually feel the mechanical thump of the atrium contracting.
Wait, it listens for the vibration through the blood.
It listens for the vibration and then times its own ventricular beat to match it perfectly. It gives you all the benefits of a dual-chamber system with none of the weaknesses of the leads.
That's a massive leap forward.
It really is.
So, to recap this whole journey, you start with a slow heart. You play detective. Rule out all the reversible stuff.
Yeah.
You prove that the symptoms and the slow rhythm are truly linked. And then you pick the right technology to restore that rhythm. That's all for this deep dive. Thanks for listening.
Stay curious.